في البداية يسعدني أن أكون في السيشن دي مع four of the iconic figures دكتور محمد فهمي، دكتور إيهاب سالم and دكتور تامر الشربيني and our elegant moderator دكتورة غادة الصغير. هنبدأ مجموعة من ال challenging endocrinal cases وهنبدأ مع حضراتكم ال first case. We have Nadia, a 49 years old female patient teacher, is not married and works and live in Luxor. On May in 2021, our patient went to her primary care physician because of palpitation, and also she noted she had depressed TSH in her lab profile. Actually, TSH was 0.01. She denied any other manifestation of the thyrotoxicosis, and she was re-evaluated by the endocrinologist that ordered thyroid scan and revealed that the patient had right toxic adenoma. She was initially treated with amethimazole for control and beta blocker for controlling of her manifestation. The pros and cons of two modalities of the treatment, either ablation or a surgical treatment, were illustrated to our patient, and the decision was surgical treatment. Post-operatively, she was placed on a thyroxine 75 microgram as a replacement therapy, and after 3 weeks, the patient re-evaluated by TSH that was still suppressed 0.02 with elevated T3 and T4. The dose of the thyroxine decreased by her physician to 50 microgram, and the TSH still remained suppressed. By detailed history from our patients, after starting of the thyroxine, the patient started to report some symptoms like insomnia, nausea, and diarrhea and irritability. The dose of the thyroxine was decreased and subsequently discontinued. After 1 month, she experienced palpitation, tremor, and denied any other manifestation of thyroid excess, and the patient had no neck symptoms and no visual complaint. By examination, vital sign, blood pressure normal, pulse ranging from 100 to 120, sinus regular, average volume equal in both eyes with no special character, and the head and neck showing midline thyroid scar that was healed with no palpable thyroid tissue and no cervical lymphadenopathy. Chest and heart clinically free, abdomen no organomegaly, extremities showing tremors of the both hands, and neurological examination there is a positive breast reflex with no evidence of dermopathy and ophthalmopathy. Her lab profile showing that after stopping a thyroxine, the lab is still, TSH is still suppressed, 0.02, free T4 elevated, and total T3 elevated, and thyroid ultrasound showing no identifiable thyroid tissues and no lymphadenopathy. After 2 months, TSH is still suppressed, and thyroid stimulating immunoglobulin ordered by her physician was negative. Thyroglobulin is highly elevated at 264. Thyroid radioactive scan showing no evidence of uptake in the region of the thyroid bed and also in the way of expected ectopic lingual thyroids. So, the first question here, what we can do for our patients? Our plan, controlling her manifestation. She had a thyrotoxic manifestation. You should start methimazole and beta blocker and search for the cause of her manifestation. Actually, still the cause of the thyrotoxicosis is a mystery. Patient not on thyroxine, elevated thyroglobulin, and the radioactive iodine, thyroid radioactive iodine scan showing no uptake in the thyroid bed and even in the pathway of the ectopic thyroid like lingual thyroids. Actually, in this situation, they ordered to refer the patient to the nuclear medicine department, and a whole body scan with a SPECT-CT technology revealed there is intense pelvic uptake with no radio tracer uptake in the region of thyroid bed, mediastinal, and even in lingual. MRI pelvis showing irregular lobulated right ovarian mass, multicystic with solid component, consistency with a teratoma that measured approximately 9 multiplied by 7.6 multiplied by 8.8 centimeters. Finally, the patient was referred to the gynecology oncology department, and finally, after 5 months of her presentation, she underwent hysterectomy, bilateral salpingo-oophorectomy, and the pathology revealed a case of a benign strom ovarian. This is a picture of the pathology that revealing that the patient had ovarian tumor containing more than 50% of thyroid tissues, predominantly with no nuclear atypia and typically occurring at a benign stroma ovarii. So we are facing a rare case of stroma ovarii. Stroma is a Latin word firstly prescribed in 1895 as a swelling in the neck. It is a rare form of the ovarian tumor defined by the presence of more than 50% of thyroid tissue at the cellular components and considered to be a part of teratoma. Actually, the age instance between 40 and 60, and in one of the study, like pathological study from 2 major academic centers, revealed that out of 1,390 ovarian tumor, 167 were teratoma and less than 1% containing thyroid tissue and stroma ovarii, and this was published in 2009. The clinical presentation. Actually, the clinical presentation of stroma ovarii is variable. Sometimes some patient may have abdominal pain or even mass, vaginal bleeding, and also a clinical manifestation of thyrotoxicosis that present in about 5% of these cases. Sometimes the patient may having a pseudopic syndrome, which is the presence of the peritoneal fluid, which is ascites, and hydrothorax, in the presence of other benign trauma, that are fibroma like teratoma, uterine myoma, and even cystic adenoma, which is present also in only 10 cases reported. So, first question here, what are the mechanisms of the thyrotoxicosis in a patient that having stroma ovarii? There are different mechanisms. One of them actually, stroma ovarii have 50% of tissue is thyroid, so it has autonomous function without even existence of a goiter or even thyroid gland, like our patient. Our patient had a total thyroidectomy and we have still persistently depressed TSH, so you must search for another cause. One of the modalities that we have is the whole scan and reveal that the patient had a teratoma. The second option, sometimes there is a coexistence of Graves' disease and stroma ovarii. يعني لو البيشنت عنده goiter, don't miss ان الجويتر ممكن تكون Graves' disease وممكن يبقى فيه coexistent, especially لو TSH is persistently depressed. In this condition, that trap out thyroid stimulating immunoglobulin acting mainly on the thyroid tissue that present on the neck and present on the pelvis. Rarely coexistent between thyroid adenoma and stroma ovarii, like our case, may delay the diagnosis. And here, according to the American guidelines, there are different situations that there's a thyrotoxicosis without even radioactive uptake. One of them is actually stroma ovarii.
Radioactive iodine uptake or even low radioactive iodine uptake. Actually, this case is a rare case, but in some situation, we learn something from such cases. As usual, in case of hyperthyroidism, not necessarily in every case to do scan, radioactive iodine scan, especially if the case is straight forward, like Graves' disease, having orbitopathy, ultrasound manifestation, typical of hyperthyroidism and performance of thyroid stimulating immunoglobulin. But in some cases, there is discrepancy between the laboratory manifestation and the clinical manifestation of the patient. In this situation, we must do radioactive iodine scan. One of these situations, according to the clinical presentation of the patient. If I have a patient with hyperthyroidism with painful thyroid gland, local tenderness, this is a case of thyroiditis. So scan here plus other laboratory manifestation is necessary. In case of painless thyroiditis also, and discrepancy between clinical and the laboratory manifestation like postpartum thyroiditis or exogenous thyroid intake, either intentional or non-intentional. In case of amiodarone therapy, there is strong indication of radioactive iodine scan. So there are different indications for doing radioactive iodine scan in hyperthyroidism, because not necessary to be this case straightforward hyperthyroidism due to Graves or toxic multinodular goiter. Okay.
The question here, what are the factors that increase the risk of the recurrence? يعني ايه الفاكتور اللي انا متوقع فيها even قبل ما ابدا تريتمنت العيان وبعد ما احنا وصلنا للدايجنوزس انا متوقع الحاله دي ممكن يحصل فيها recurrence. One of the cases that ovarian tumor, large ovarian tumor, more than 70 centimeter, the presence of the peritoneal fluid, a size more than 1 liter, the presence of ovarian, extra ovarian spreading, or the presence of the adhesion. And finally, if the patient has a papillary histology, as there is increase in the conversion of stroma ovarii to a malignancy, especially papillary thyroid cancer or even follicular thyroid cancer, or even follicular variants of papillary thyroid cancer. I think Prof. Ghada Saghir will ask us how to treat and how to follow. So the treatment. So the treatment actually is giving the patient antithyroidal medication and to controlling hair manifestation, give methimazole and beta blocker like our case, but the main treatment is surgical removal of the tumor. The ovarian tumor, like teratoma, even it's benign in our case, sometimes there's increasing in the conversion to a malignant like papillary thyroid cancer. After treatment, how to follow?
زي ما قالت دكتورة منو, the main line of treatment, medical to control symptoms, beta blocker if indicated, but the main line of management is the surgical treatment. Surgical treatment for possibility in the teratoma have an incidence of papillary thyroid carcinoma. So, some case of high risk for development of papillary carcinoma, we must do strict follow-up for this case. يعني مش هعمل أنا الجراحة وخلاص. لازم فولو اب بعد كده. الفولو اب وخاصه لو البيشنت ده عنده هاي ريسك اوف ريكارنس اوف تيومر بالثايروجلوبين ليفل زيها زي حاله كانسر بابيلاري كارسينوما او فوليكولار هنعمل اسسمنت اوف ثايروجلوبين ليفل. لو في انكريس في الثايروجلوبين ليفل يبقى انا عندي اندوجينوس هايبرثايروديزم ستيل سكريتنج ثايرويد هرمون في ثايرويد تيشو سكريتنج ثايرويد هرمون. The next step to do again whole body scan for radioactive iodine therapy, and the treatment may be ablative therapy with radioactive iodine according to the situation.
As Prof. Ghada said that the recurrence is one of the risk factor for ovarian tumor, like our case stroma ovarii, and the risk is increasing with the malignant cases. Also, one case report in a benign stroma ovarii, there is a stromosis, peritoneal stromosis, so the follow-up is mandatory for all cases. So our take-home message, stroma ovarii can present with a typical manifestation of the thyrotoxicosis and especially expected in the patient that have a persistent suppressed TSH even in absence of thyroid tissues. Whole body scan radioactive using SPECT-CT technology is one of the modalities for diagnosis and for follow-up of your patient. And finally, the curative treatment of stroma ovarii is a surgical removal, either unilateral or bilateral with a hysterectomy because of increasing conversion to malignancy like papillary thyroid cancer. Thank you.